Hi everyone, this is your voiceover on the cardiomyopathy content of heart failure. So cardiomyopathy is a subacute or chronic disorder of the cardiac muscle or myocardium. Most of the time it is due to remodeling, maybe after damage, but it can be due to infections, connective tissue disease, toxins, nutritional deficiencies. There may be a genetic component to it. And there are different classifications as well. So the most common is dilated cardiomyopathy. And when we say dilated, we're referring to the ventricles being enlarged. Hypertrophic is referring to the hypertrophied muscle. So the walls are enlarged. The walls of the ventricles thicken and become stiff. When least common is restrictive, it's a little bit of a combination of both systolic and diastolic heart failure that it can lead to. And in restrictive cardiomyopathy, the walls of the ventricles become stiff, but not necessarily thickened. And arrhythmogenic right ventricular cardiomyopathy or dysplasia results from replacement of myocardial tissue with fibrous and fatty tissue. Although the name implies right ventricle disease, about a third of patients also have left ventricular involvement, and this disease has a familiar or genetic component to it and often affects young adults. And some patients have symptoms and others do not. So first, dilated cardiomyopathy or DCM. It is caused by dilated and weakened ventricles. So the ventricles are enlarged. It involves extensive damage to the myofibrils and interference with myocardial metabolism. And because both ventricles are dilated, possibly the left ventricle might be worse. The systolic function is impaired. Could be caused by alcohol, chemo, infection, inflammation, poor nutrition. And the decreased cardiac output from inadequate pumping of the heart causes the patient to experience dyspnea on exertion, decreased exercise capacity, fatigue, and palpitations. And they can have a risk of prevalent wall thrombi as well. And if you see on an x-ray, you'll see the dilated side of the heart. And if you look at a normal versus a dilated cardiomyopathy patient, look at their ventricles, you'll see that the size is enlarged with the dilated cardiomyopathy. Some signs and symptoms: fatigue, weakness, they're at risk for clots, they might have a cough, they might experience dysrhythmias, and they'll experience cardiomegaly. And how do we treat it? We give them vasodilators, we give them medications to control the dysrhythmias, and eventually they may or may not need a heart transplant. The second classification we'll cover is hypertrophic cardiomyopathy or HCM. This occurs when there is asymmetric ventricular hypertrophy and disarray of the myocardial fibers, and left ventricular hypertrophy leads to a stiff left ventricle, which results in diastolic filling abnormalities. Remember, when the ventricles are enlarged and thick, they can't relax, they can't fill. So most likely, this hypertrophic cardiomyopathy, since we're talking about the changes in the actual heart muscle, we are often going to see diastolic dysfunction. It is a genetic disorder. We're thinking it's an autosomal dominant genetic disorder. And some patients are asymptomatic, and they actually can cause sudden death. You might have heard of maybe young high school athletes who just die suddenly, who haven't been diagnosed with prior hypertrophic cardiomyopathy. And what is the cause of the sudden death? Ventricular arrhythmias that can put them into cardiac arrest. And other symptoms, if they're not asymptomatic, they might present with dyspnea, angina, fatigue, syncope, palpitations, again that is a result of the ventricular arrhythmias, and they're going to have mild cardiomegaly. So if you see a cross section of a normal heart versus a hypertrophic cardiomyopathy heart, same concept with diastolic heart failure. Because the walls thicken, they take up the normal space of the ventricles, so there's less space for the blood to fill. So as the muscle hypertrophies, it's decreasing the chamber size. And restrictive cardiomyopathy, the stiff ventricles restrict filling during diastole, and the fibrosed walls cannot expand or contract. So you can think of it as a combination of both systolic and diastolic dysfunction. It can be due to endocardial or myocardial disease like sarcoidosis, amyloidosis, and very similar signs and symptoms, similar to left or right heart failure. How do we diagnose cardiomyopathy? We can do an echo to check ejection fraction. We can do some nuclear studies. It can be detected during a cardiac cath or angiocardiography. Chest x-ray might show cardiomegaly. BNP might be elevated due to the left ventricle becoming enlarged due to fluid overload. And we can also do a myocardial cell biopsy as well to diagnose myocarditis or amyloidosis. Non-surgical management, initially, especially with dilated or restrictive cardiomyopathy, is the same as heart failure. You can use diuretics, vasodilators, cardiac glycosides such as your digoxin to increase cardiac output. And because patients are at risk for sudden death, we need to teach them to report any palpitations, dizziness, or signs and symptoms of fainting, which might indicate a dysrhythmia. And antidysrhythmic drugs or implantable cardiac defibrillators can be used to control life-threatening dysrhythmias. Beta blockers can be used to decrease sympathetic stimulation, prevent tachycardia. And obviously, if the cardiomyopathy has been developed in response to a toxin or alcohol, you need to avoid further exposure to that toxin. And surgical options. The type of surgery performed depends on the type of cardiomyopathy. The most commonly used surgical treatment, you might excise a portion of the hypertrophied ventricular septum to create a wider outflow tract, which is a myomectomy. And this can help with long-term improvement in activity tolerance for a lot of patients. For hypertrophic cardiomyopathy, you might do a septal ablation, which is another option. You actually inject absolute alcohol into a target septal branch of the left anterior descending coronary artery to actually induce a small septal infarction. And a patient with arrhythmogenic right ventricular cardiomyopathy who does not respond to drug therapy may have a catheter ablation or an implantable defibrillator. And as a last resort, heart transplant is a treatment of choice, especially for patients with severe DCM and may be considered for patients with restrictive cardiomyopathy. And it can also be done for end-stage heart disease due to CAD, valve disease, or congenital heart disease. And that pretty much covers all of your classes of cardiomyopathy. And let me know if you have any questions.